Welcome. I'm Risa Dixon, Interim Vice President for the Office of Academic Affairs at Palo Alto University. It's a pleasure to welcome you to our webinar series, At the Forefront of Mental Health. Palo Alto University, or PAU as we say, is dedicated to addressing the pressing and emerging issues in the fields of psychology and counseling. Today's webinar on the impact of disasters, disease, and disruption on mental health couldn't be more relevant as the world copes with a global pandemic and natural disasters such as wildfires and tropical storms. In a moment, you'll hear from two of our faculty who are experts in the field of disasters and mental health. But before they get started, I have the pleasure of introducing today's moderator, ABC7 news anchor and journalist, Amma Dates. Amma has been a local anchor for over 10 years. She has reported on numerous health-related stories during the pandemic and how it's impacting the lives of families in the Bay Area. Amma began her career in television in Fresno, followed by stints in Texas, Michigan, and Sacramento before joining Channel 7. She's a graduate of Loyola Marymount University. Thank you so much for joining us today, and welcome.
Thank you. Thank you, Vice President Dixon. It's a pleasure to be here. I'm so glad so many people could join. This is such an important topic, especially right now. It's extremely relevant. Today's presentation will explore elements of broad-based community and public health preparedness and disaster mental health responses to large-scale adversities, including natural as well as human-caused disasters, pandemics like we're going through right now, as well as climate change. Our panelists will discuss the strengths and weaknesses of our current disaster mental health responses, especially in light of COVID-19, which is hitting us so hard right now, and address ways that we can be more effective as well as prepared for future disasters and care of vulnerable populations. So we have a lot to cover today. Before we get started though, we have a little bit of housekeeping to take care of. The webinar is actually going to be recorded and then a link will be sent to you within a week. So if you, for some reason, have to turn your attention away, don't worry, you will be able to get all this information again at a later date. We're going to get that link for you. And we're going to leave time at the end for questions. I'm sure a lot of you will have follow-up questions and we want to make sure to get to as many as we can. So use the Q&A function. It's at the bottom of your screen. And please note that if your question is for a specific panelist, so I know who to address it to at the end. So everybody ready? Let's get to our panelists. They are experts in the field of trauma as it relates to disasters and events such as pandemics. Joining me today, we begin with Dr. Lisa Brown, who's a tenured professor at Palo Alto University, where she directs the trauma program and the Risk and Resilience Research Lab and is the faculty advisor for the Association of Traumatic Stress Studies. Dr. Brown's research focuses on aging, vulnerable adults, and disasters. She's on the, practiced this word so much, the Gerontological Society. I saw it and I got nervous because it's just not the word I say every day. All right, Gerontological Society of America's COVID-19 Task Force, and was the lead author of the Psychological First Aid in Nursing Homes program. She has published more than 50 journal articles on aging and disasters. And we also have Dr. Josef Ruzek. Did I get that right?
Perfect, perfect.
All right, I'm practicing that one too. He's a research professor at Palo Alto University. He is co-director of PAU's Early Intervention Clinic and Center for M2 Health at Palo Alto University. The Early Intervention Clinic is dedicated to developing and evaluating different methods of treatment for trauma survivors. Ruzek is a co-developer of several psychosocial interventions and is also a co-developer of many internet and mobile phone interventions, such as My Disaster Recovery and PTSD Coach, which I'm actually interested to learn more about that as well. So if each of you would like to talk a little bit first, just to give a little more of an introduction about your area of expertise. Lisa, why don't we start with you?
Okay, thank you, Amma. Pleasure to be here today. Yes, as you mentioned, I've been really involved with the Gerontological Society of America, and they've developed a number of products now that are also being made available through the CDC and ASPR. But you can go, if you're interested in anything I'm talking about today, to GSA COVID updates and learn all about the new products that are available. They're free of charge. One of the things that I spearheaded with a group of my colleagues at GSA is a decision aid that actually can help people figure out their personal values and their risk factors in terms of, should they go back out into public? Should they have friends over for Thanksgiving? Oftentimes there's decision aids that are available, but they don't fully take into account medical conditions and values that that person might have that are centered around particular events. So that decision aid has gotten massive traction since we put it up. We've already translated it into Spanish and Portuguese, and it's being disseminated throughout South America. It's also in Chinese, and so it's really got legs of its own. Recently, I had an opportunity this past summer where I was appointed to a presidential commission for CMS. And as you are probably well aware of, we had a lot of older adults in long-term care settings who are dying from COVID-19 infections. And in large part, it was initially because we simply didn't recognize what was going on. But once we did, we still had a very difficult time reining this disease under control. As an infectious disease process, I was really pleased that they included me on their commission, their 25-member commission. So they had some mental health input. And my argument has always been that you can be providing care to people, but you can do it in a way that is beneficial to them, that helps them maintain their well-being, that helps them cope, that helps them contend better with the social isolation. And so that commission report now has come out. And it's the Coronavirus Commission for Safety and Quality in Nursing Homes. So those are the two things most recently that I'm really involved with and that have been fairly high profile.
Fascinating. Okay, Joe.
Well, I came to this as a cognitive behavioral psychologist, and I was always interested in figuring out how psychology could have a maximal impact on human well-being. And I was interested in taking psychology out of the mental health clinic and the medical model of disorders and disease, and figuring out how to help it, bring it to bear on helping people live more effectively. So when I got involved with post-traumatic stress disorder, which occurred when I joined the VA's National Center for PTSD, where I was there for 26 years and I was one of its directors for the last 10 years. I specialized in early intervention to prevent development of PTSD, rather than waiting for people to come into mental health clinics after they've had many years of difficulty. And incidentally, most people don't come along for formal counseling help. I thought, gee, there are probably a lot of places in society where we could get hold of people soon after they've had a very difficult experience and help them with that, and hopefully prevent a lot of long-term effects of those things. So I did it in a lot of ways. I did it with combat stress control. I did it with sexual assault programs. I got interested in adding mental health to hospital emergency room functions. But in particular, I got involved in disaster. I was involved from the beginning at Loma Prieta earthquake in the Bay Area, when colleagues and I began to formally apply ourselves to thinking about disaster and how to do it. So a lot of my career has been spent on looking at the larger scientific literatures on early intervention to prevent PTSD, most of which is being conducted outside of the disaster space, and trying to figure out how to bring that knowledge and expertise to bear on disaster response.
That's interesting. I really like that you're looking at early intervention, trying to help people not get to the point where they feel so desperate and hopeless. And Loma Prieta, my goodness, anytime there's any sort of rumbling, my heart stops and I'm just, is this the next big one? Is this it again? Joe, can you talk a little more specifically about your work with natural disasters? Because you were very involved in the Sonoma fires, and climate change is a great concern of yours. What are the possible effects? Are these fires because of the climate change? What's really happening? Or, a lot of people say deforestation. What is going on here? What is your view?
Well, I do personally view all of the increase in various kinds of natural disasters as being usually linked to long-term processes of climate change. I think that that's fairly transparent in the context of the California wildfires. But it's also true in the increasing hurricane frequency and intensity, and globally it's very important. I have become interested in thinking about these things globally, because to some degree in the affluent West in the United States, we have at least some protections in place. The kinds of disaster mental health services we're talking about today, the US at least has infrastructures for this, and it has funding for it, and our economics protect us from a lot of the fallout. But if you look more globally, especially in low and middle income countries, they're going to be savaged by global warming. So the impact of global warming and climate change is likely to show itself in a variety of ways. One, of course, is just the increase in disasters that affect us. So as you can see, we all have the sense, and it's objective data, that we're having to respond to more and more disasters more frequently now, and it's getting on all of our agendas. But also, climate change is going to impact people in other ways other than the impact of disasters. For example, as the world gets hotter, heat causes all kinds of social problems and exacerbates mental health difficulties. When a lot of the things that we are actually experiencing worldwide are fallouts from effects of climate change, namely human migration. As in rural settings, droughts and other ecological disasters make it harder for people to sustain themselves. They start to move, and as they move, we overwhelm the places that they move to, and that creates social conflict and creates a lot of additional mental health and social and behavioral consequences. And then finally, the thing is that we also have something we might call eco-anxiety, which is that young Americans now, and older Americans as well, are growing up in an environment where we are feeling overwhelmed by the degradation of the planet. The kind of doom and gloom, catastrophic scenarios of global warming, species extinction, causing a kind of a form of existential despair and lack of hope in many people, especially those of who spend time watching the media in a constant barrage. So I think it's going to affect people in a lot of ways.
And I think a lot of people want to help, but they don't know how to help, and it's overwhelming.
Mm-hmm.
Well, I think the mental health aspects of climate change and global warming have been largely overlooked. Anyone on this call who's interested should look at the American Psychological Association 2017 report, because it really lays out the state of the science and what's known about global warming, climate change, and mental health. I do believe that we as mental health professionals, students at PAU and all of us, should get involved in these issues, in disaster mental health and in climate change. And there are various ways in which we can help in our professional roles to raise awareness of the mental health effects of all this.
Yeah, absolutely. Lisa, let's turn to you. You actually help work on developing disaster response plans for older adults and other vulnerable populations. Your experience, as you mentioned, includes preparing for a hurricane, and you're involved with the COVID-19 efforts. Talk a little more about these projects, especially now because we're rolling back, we're having more restrictions because of COVID-19. What is your view on how things are going with this and how we are protecting our older populations? Are we doing enough? Do we need to do more?
Yeah, I think it's a really big challenge that we're all contending with. I know with older adults, one of the things I realized early on was, as a vulnerable population, they oftentimes are clumped together. So everybody 65 and above is considered to be an older adult. But yet, just like children, a newborn to up to age 18, they're considered children. There's developmental differences. So one of the things that I've been really trying to drive home is that we need to take a more nuanced or fine-grained approach to how we provide services, mental health services, and all types of care to people who are older, and that many of them are capable of being volunteers. They're part of the solution. They can help deal with climate change. They can be outreach and supporting of both older adults as well as younger adults. It's not limited to their age group. But I think because we clump everybody together, 65 and older is vulnerable, we lose out on a really crucial part of our population in terms of the response process. I know that one of the things that really drove me to get more involved was the hurricanes when I was living in Florida. I would see time and time again, and rightly so, many of the materials were pretty much focused in on younger adults and children. When you look at the original version of psychological first aid, it's really focused on younger populations. And so I was able to get a small amount of money from Psychology Beyond Borders and develop with a slew of colleagues materials that were appropriate for older adults who are in different settings. And the settings for older adults really are sort of a proxy. They give you a clue in terms of what types of services might be most useful for them. So for example, somebody in a skilled nursing facility, they're going to have high needs, but they're also going to have a lot of built-in regulations that protect them from moment to moment, which is why COVID was so surprising and so damaging, because they were ready for physical disasters. They were not ready for a pandemic. And so even though we talked about it, the reality, there's a gap between the reality and what actually occurred. So I think that that's a really good example of how we need to think about in the future about right now. Joe was talking about earthquakes before. We could have an earthquake during this pandemic. We could have a fire. We did have fires during this pandemic. And when you've got different types of disaster management techniques that are not necessarily working in tandem with each other. One requires physical distancing, the other wants you to come together as quickly as possible in order to remain safe. It's not something where we fully have ironed out all those problems.
I'm interested, resources are always a big concern for any organization. For the Gerontological Society of America, you're working on that task force. Do you feel you have adequate resources to deal with whatever might happen?
You know, I think we do. I think that there's different phases of a disaster. Typically, people think about mitigation, preparedness, response, and then recovery. I think right now, our attention now with both Pfizer and Moderna coming out with a vaccine that looks viable, I think our large concern right now is making sure that we're reaching populations that may be reluctant to get vaccinated for any number of reasons, and wanting to make sure that we're inclusive, that people are included in that process. There's tricks involved in terms of refrigeration requirements where some vaccines may be readily available for one group but not another, but that's no reason for people to delay getting vaccinated if one's made available to them. So I think a vaccination effort is now going to be an area where a lot of these organizations will start to ramp up a lot of their energy and a lot of their resources.
Okay. Joe, let's go back to you. Talking about addressing disasters through this mental health lens, pre and post disaster. What are some examples of approaches that specifically target disaster mental health? Because I think that's a little different than just everyday life, although everyday life, I think for a lot of people feels like a disaster these days.
Yeah, I mean, I think, we can think of disaster mental health response as being a kind of, quote, stepped care response, right, with several layers of intensity. The lowest layers of intensity are aimed at everyone in the entire population affected by the disaster. And then it moves towards targeting more and more affected subgroups. So Lisa talked a little bit about her adaptation of psychological first aid. Psychological first aid is the thing that we do for everybody in an affected zone. And it typically means it's really not very mental healthy at all. In fact, it bends over backwards to not really use mental health terminology or labels, because we're sort of in a model of pathologization, and we don't want to do that for ordinary reactions to bad, stressful experiences people have. So, PFA responders move out across the community wherever they can find people, in shelters, on street corners, in business organizations, and they provide education and information, a little bit of pragmatic problem solving about the next things people need to do. And they link them with helping services and try to make sure they strengthen their ability to get support from the people that they know and love. That is sort of what everybody gets. Then at the other end, if we find someone who has a quote mental health problem like PTSD or diagnosable depression, we try to get them into actual mental health treatment. That treatment for disaster mental health doesn't look a lot different than what it looks like for anybody with PTSD from any source or depression. I've been interested in something intermediate between the two because, PFA, psychological first aid, probably doesn't prevent the development of depression, anxiety, substance abuse in the high-risk people that are probably going to get it. We have no data showing that a single session of brief support, advice, and linkage will have the function of actually preventing problems in the high-risk groups. Now, remember, almost everyone is exposed to disaster, and indeed in any trauma, most people don't develop what we would call mental health disorders. After a period of time, they go back, if not to normal functioning, at least to some level of functioning that doesn't involve, grave impairments in their life. But there are subgroups of people who, by virtue of individual vulnerabilities, their past history, but also by virtue of what they experienced in disaster. Because, a disaster hits you, some people have mild exposure, some people have extremely intense experiences. The people who are at risk for developing problems could benefit from more kind of intermediate intensity programs. So for example, I've developed some 5-session interventions that are aimed at being kind of broadly preventive, simpler to deliver, easier to disperse than the mental health treatments. One's called Skills for Psychological Recovery, and it teaches people simple skills that have been found to be effective in many contexts, like problem solving, positive activity scheduling, simple stress management tools like deep breathing, enhancement of social support, and the like.
And is that PTSD coach app, is that something anybody can just log on to and get access to?
Yeah, well, courtesy. So this was something that was developed during my time at the Veterans Administration National Center for PTSD. And I saw the need to try to leverage technology for a whole host of mental health difficulties related to trauma and so on. So PTSD coaches, I think, being downloaded in 96 countries. I think it's something like 750,000 times now. But because it was a government thing, it's not a commercial thing, it's absolutely free to everyone. So anyone can download it. Now, PTSD Coach wasn't strictly designed for disaster. It was designed for PTSD, but a lot of what it offers, for example, a self-assessment of your own stress reactions or stress symptoms. And it tells you what your scores mean, and you can track your symptoms over time and it will re-administer it. It also teaches you deep breathing and physical muscular relaxation training. It gives you information, it links you with emergency services and so on. So it's a pragmatic tool. And I think that these kinds of technologies will increasingly be integrated with psychological first aid, with treatment, with a whole array of disaster mental health services, but they'll enable us to reach much larger numbers of people quickly and also link people with more intensive helping services. I also think that it will help people, mental health counselors and other helpers who are charged with responding to disaster survivors, but who are not themselves trauma experts. It'll help them give something of value to the people they work with if they incorporate it into the care they provide. So we haven't yet seen large-scale effective bringing to bear of technologies on disaster, but I think that over the next decade is going to accelerate a lot.
Yeah, I think so. We're seeing a lot of telehealth now that people are quarantined. I really think it's a step forward and it's easy access for a lot of people, especially in mental health, who may not be ready to take the next step to seek professional help. It could help bridge the gap. Lisa, what have you seen by way of technology in your responses to mental health and disasters?
I think that's a good question again that really has a lot of bearing in terms of what setting the older adult is residing in, or any person's residing in. I know even within my house, I have dead spots. And I'm sure that a lot of us experience that. And it's problematic. And so when I think about people who are maybe homeless and they're housed in a shelter, it may not have Wi-Fi, it may not have the amenities necessary to get online. Same thing with a lot of our long-term care facilities. They tend to be older buildings, and there tends to be less demand for connectivity. So I think there are pockets of our population that run real risk for being cut out of the loop. There's an organization called Pew, P-E-W, and what they do is they track how many people in the United States have connectivity, and is it in the form of a smartphone or a tablet or a desktop computer. And that's really helpful. Though that information that they provide gives us an idea of the type of reach we might have with any particular group within the United States. And so oftentimes I'll turn to that to get a better idea of where to target my resources and how to do it.
Yeah, I think that's a good point. You don't want people to be left behind. A lot of the older generations have a little trouble getting online or even knowing what to do or where to start. And if they don't have someone in their life who can help get them connected, it can be a big challenge. Speaking, since you've done COVID-19, you've done hurricanes, how does the mental health response for you differ, just on a very basic level?
Well, with hurricanes, I actually was out in the field afterwards. So I worked as in a public shelter for the American Red Cross and delivering care to people after a series of hurricanes in Florida. And then also for the Medical Reserve Corps, part of their team and part of their planning team, and getting out into the field. And that's been really instructive because it gave me some ideas about how things were actually working in real time and what people were really grappling with. There is a distinction between the crisis counseling that Joe and I are talking about today and psychotherapy. In that psychotherapy, the goal is basically to enhance functioning, where with crisis counseling, it's to restore functioning. And there's been ongoing discussion recently about, is restoring functioning to baseline appropriate, given that fact that some of the people who have been adversely affected may have had challenges before that event occurred. And so how do we best help people in a way that really does make a difference, that's enduring, that's targeted, that makes sense given the resources? And so I think with COVID-19, it's different because I'm not out in the field. With physical distancing, I don't like the term social distancing at all. I think we need to remain socially connected, but physically apart. And so I'm really, if I could have a campaign, it would be to get rid of social distancing. But I do think that just trying to come up with innovative ways that people can stay in contact. I think the media has been very good about getting a lot of creative ways out, highlighting successes that people have had, because I think it's going to be something that we're going to be grappling with until we get a vaccine that has widespread uptake. So delivery of services has been sort of challenging. And right now we're doing a study to look at some of the issues clinicians have had out in the field, using telehealth, getting support from their administrators. There's just a series of things that are either working or not that we're still beginning to understand.
Yeah, I think you're definitely spot on. I'm curious how, Joe, maybe you can answer this. Mental health professionals out there trying to help everyone else, but they're going through the same things that the people they're helping are going through. How do those professionals help themselves in that time?
Whenever you train people to be a disaster responder, we always spend a lot of time on talking about self-care. And the ways we encourage people to engage in self-care are often incorporate many commonsensical things and many things that we include in our interventions for survivors themselves. You know, everything from doing various forms of physical relaxation to maintaining strong social contact with friends, to trying to continue to engage in enjoyable activities that lift your mood, to, and particularly for professionals, doing things like taking time off and taking vacations and all that. But there is a bit of a difficulty, particularly for disaster responders, and that is that, you know, you're in it with a mission to help other people, and the seeing the people around you suffering tends to trump self-care. Many times people feel that they're the only ones that could be there to help, or that they need to do it because there's so much suffering around them, and so they take shortcuts. It is a real problem. You know, doctors and nurses in COVID are likely to be amongst the hardest hit, particularly if they're working in environments where there's been very high caseload, you know, witnessing a lot of suffering and death and overwork. You know, as we saw, you know, in the beginning in New York, and we've seen in many other places. And we typically don't have, I think, very sophisticated, well thought through, well implemented programs for looking after mental health professionals. So a lot of it comes down to mental health professionals being aware of all the, you know, the guidelines for self-care. The problem with that is people are not necessarily very good at following through with these things. You know, if you go and you give a talk to a group of healthcare providers, including mental health professionals, and you talk to them about the do's and don'ts of coping, you follow them up 6 months later, I don't think you're very likely to see that they're all, you know, industrial strength engaging in all this self-care. It's not that easy to change people's behavior. So the role of managers and structures in organizations becomes very important. Managers need to make this clear that these things are expected and build it into the environment, model it themselves, and hold people accountable for self-care. But it is a real, it's also a strength, you know, the fact that we as mental health professionals are experiencing it does give us a bit more connection and perhaps sometimes a little more awareness than we might find with some forms of mental health care that we deliver. So it is a real problem, though. You know, no one is unaffected by this.
Yeah, absolutely. It's a tough time. And I think a lot of people on the front lines who are helping other people, they think, well, I don't have it as bad as this person, you know, I'm just going to keep going. And then it just builds up and builds up. Lisa, any comments on that?
No, I think that Joe really hit the nail on the head. I think that it is really problematic and that people do feel mission specific. And sometimes just telling somebody it's time to take a rest and go home can be a really difficult conversation under certain circumstances. So yeah, it's an ongoing issue. I think that nurses and people who have been direct care providers, again, in long-term care facilities, I think the media has done an excellent job of basically celebrating and recognizing the sacrifices that people are making in hospitals, but they're making equal types of sacrifices in these long-term care facilities, but yet, and many times they're sort of demonized, you know, for all of these deaths that have occurred, that you've got surveyors and other systems in place to regulate and to monitor. So I think that again, it very much is setting driven in terms of how much support the environment is providing or not.
Yeah, that's a good point. And Lisa, let's stick with you. You talk about all the deaths we've had at some of these long care facilities. What are your greatest concerns regarding a widespread disaster, and why aren't people adequately prepared?
You know, I think that until COVID-19 happened, that, you know, disasters were largely sort of geologically discrete. They would be geographically discrete. They'd be like in one area. If you look at FEMA, you can see where we've had, as Joe was talking about before with climate change, we've had a steady uptick in terms of not only the number, but the duration of these events of all types as a result of our contribution to climate change as humans. And I think that, you know, again, trying to struggle through all of this and trying to make sense of it And I just lost the question again. Can you tell me? I was thinking like 2 steps ahead.
I know it was your greatest concerns with a widespread disaster and why people aren't prepared.
And so it's a low base rate event. That's where I was going with all this. Disasters are typically low base rate events. I know when we got out into the field, one of the things that really was eye-opening for me was we were asking people in Oakland, why were they not prepared for an earthquake? Why were they not storing water and food? And it really boiled down to a lot of them live in rental buildings or they live in really small areas and they don't have the space or the income to be able to buy all of these goods and to store them up. So I think when you've got a low base event coupled with storage issues, coupled with financial issues, that it's really hard to make an argument. I think that oftentimes we'd be better off telling people the minimum that they need to have in order to survive for like a 3-day period. If they want to be better prepared, this is the next step up. Joe talked about step care. I'm talking about going upwards. A little bit more that they could do to remain safe. But I think oftentimes we present preparedness in an all or nothing format, which makes it daunting. And people just say, oh, I'm going to just throw my hands up and call it a day and not do anything.
Yeah, I think some people are getting better though, because of all the power shutoffs that we've had, knowing that they're going to be without power for a few days. I think that did prompt some people to, okay, let me go out, let me get the non-perishables, let me make sure we have enough water, batteries, flashlights. So, it's an unfortunate situation, but however, I think it did prompt some people to start thinking about getting somewhat of a plan in place. Joe, any comments?
Well, yeah, I do think that we don't do a good job in preparations for disasters for the mental health side. In fact, part of the problem is the institutional resourcing is very poor. Most states have a disaster coordinator. It's often a collateral duty. They don't have any staff. They don't have any money. There are extreme limits on what they can do with this enormous catchment area that they're trying to help. And also, the thinking is still a little old, right? There's more awareness of the need to get supplies stockpiled or medicines or things like that than there is for the psychosocial impact and the mental health aspects of it. So even disasters themselves, everything kicks into motion after the disaster takes place. Mm-hmm. They may have had some small efforts at preparation, but everything happens afterwards, and then it runs its course for 2 or 3 years. The federal funding stops, and the whole thing shuts down. So we're not building any kind of infrastructure. I know when I was involved in the Sonoma County Wildfire Collaborative, I said to them that you've done all this work at building a large network of professionals, training people, and standing up the My Sonoma Strong website, an app. You need to service these things and make them standing resources, because you're going to have more fires, you're going to have more community events, but they don't have the resourcing. The organizations are ad hoc creations that come into being to respond. I tend to think that these areas like Sonoma County or some of the places in Hurricane Alleys might be the places where we could see a paradigm change, where they begin to invest in developing a standing capability of responding to adversity. And we need to think about how to integrate that with all of the other more proximal problems. Because, why does this happen? It happens because the decision makers at all levels are putting out fires, and their constituents don't necessarily support them taking big chunks of money away from other issues to put into something that, as Lisa pointed out, may or may not happen, right? But it's a short-sighted way of responding to these events. And I would argue that investing in the mental health and resilience of communities and larger groups would yield benefits across the spectrum, from all the kinds of problems that people are experiencing in all the more narrow sectors of society.
I think you're right, though. I think we will start seeing a shift, because it went from maybe a community disaster, a shooting at a high school perhaps, and then they'd send in a counselor or two to help other kids. But now we're starting to see these disasters that we know are going to come every year, like the fires, and then the pandemic on top of that. And we're really starting to feel and see the wear and tear on people emotionally. And I think now people really have to start taking that step and making sure that they have the resources in place ready to go. And it's sad that it took so much to come down on us to really get to that place. But I think at least now we are starting, and even just having this conversation, I think is a big step forward too. Lisa, do you see some strengths in the current approaches that we have to disaster mental health?
You know, I think the fact that we're talking about it more, and there's a realization that you can be handing out a bottle of water to somebody in a shelter and at the same time providing some element of psychological first aid to that person receiving the water, that they don't necessarily have to be discrete actions, and that you can train everybody up, just like medical first aid. People can be trained up to use psychological first aid, and they should be trained up to use psychological first aid in the same way. You know, the way we talk to each other and how we talk to each other has direct bearing in terms of our mental health and our well-being. That if I'm in a situation and I'm struggling to deal with some situation and you deal with me very poorly and rudely, that's what I'm going to really remember, and that's going to make the situation far worse. So I think the fact that we're having discussions like this today, I also think that when Joe was talking about the fires, you know, if we look at what the fire departments do, you know, in between fighting fires, they're out there teaching resiliency, they're out there teaching fire safety to the community. They're out there doing checks in terms of, you know, different types of foliage that are growing too close. They're busy building up the community. They're not just always responding to fires 24/7. And I think if we take that model that fire people are using and apply that to disasters, where we have a disaster, we don't have the brain drain that Joe just described, and they've got plenty of resiliency building work to do, they could be kept busy all the time, appropriately so, where they're really doing a service to the community. But we haven't moved to that point yet, which is where I think we really need to go.
Yeah. Joe, I'm curious, what about volunteers? Could they easily be trained to at least sort of be a frontline, sort of a go-between at all? I know mental health is something you really need to be trained in to help people, but is this something that volunteers could maybe get a little bit of training just so they know how to respond? Perhaps when someone says this, oh, maybe it would be helpful if I said this, for example?
I have two answers to that. One is a little bit, if I may be heretical with Palo Alto University and our professional discipline of clinical psychology. The evidence suggests that lay people, just ordinary people with a little bit of human sensitivity, can be trained to deliver the most complex evidence-based psychological therapies for trauma survivors and get just as good impact as mental health professionals being trained for 10 years. So for example, in the Congo, right, lay women villagers have been trained to deliver cognitive processing therapy, one of our gold standard interventions for PTSD, and they get great outcomes. They simplified, they have to be trained and supervised, which itself requires an infrastructure. So internationally, most countries, you know, especially the lower income countries, middle income countries, don't have the kind of health or mental health infrastructures that we have in the United States. So now the World Health Organization, other international organizations are thinking of this thing called task shifting, in which you get lay people and train them under supervision to deliver mental health interventions. And the data that's coming in is very supportive of that. So first, your question is, yes, lay people can be trained to do even fairly sophisticated things. I also think that there's a need to explore a lot of other ideas. I'm involved right now with a program called GRIT, training GRIT coaches, Greater Resilience Implementation Teams. We're doing this in Colorado. Lisa, it's our old friend Chip Bennett.
Yeah.
And so we designed a brief training program to help anyone who wants to better support their family, friends, neighbors, and acquaintances, people they know, not people they don't know, and to enhance they're natural helping conversations. You know, we took a look at, well, what do we think is good about when somebody reaches out to a friend or family member? And what do we need to strengthen that conversation? So we strengthen the conversation, but in several ways, but the simple one are we make sure they ask about how you feel and how you're doing, to open up the conversation about emotional well-being. And then we have them ask about what are you doing to cope? What's working for you? So they can identify and strengthen positive coping that the person's already doing to give it a kind of positive strength, resilience twist. And then we also give them resources, right? We encourage them to use the technological tools which are out there, like COVID Coach, like PTSD Coach, like My Sonoma Strong. So we think that, and we've had 1,300 people so far sign up and take that training, and they're going out and just interacting with the people they know. Now, this is a new experimental thing. I don't know if it works, but it seems like a good idea, right? So the idea is figure out ways to break down evidence-based helping methods and give them away and propagate them and take them out of the hands of just mental health professionals sitting in little rooms, at great expense, interacting with one person at a time.
Yeah, that's fascinating. Okay, I want to get to some questions because we do have some from some of our attendees on here. So whoever feels best at answering either of these, I'll leave them open to either. Let's start with Stephanie Brambila, who says, hello, I'm a PAU alumni. How wonderful to see you both on here. I wonder if you can recommend a way to become more educated in early intervention for trauma. Any book recommendations?
Well, I can do one quick stab. If you are a student at Palo Alto University, I couldn't remember, is this a question for a student?
Alumni.
Because anybody who's a student should talk to Lisa and learn, see about the trauma track, but also there is an early intervention clinic that Palo Alto University stands up, Dr. Matthew Cordova runs. It's a tremendous and extremely unusual and unique training opportunity. So do that. There is a book by, geez, I'm gonna forget his name, called Acute Stress Disorder. That is an American Psychological Association text. It's by one of the world's leading authors on the subject, and for some reason, although I've known him for 20 years, his name's he's at University of New South Wales. It'll come to me, but check out that textbook on acute stress disorder because it's a very scientific account and very, very good. If you want to learn more pragmatic tools, go to the National Center for PTSD website, www.va.ptsd.gov, and download the Skills for Psychological Recovery manual. We have manualized a brief, intermediate, intensity approach to counseling. That's really a tremendous resource. It'll teach you a lot because it's very operational on how to talk to people and what to do, skills training. And it also has tremendous handouts for people. So it's great for client education. So those are two places I would start. I don't know, Lisa, do you have anything to add about that?
Sure. Our friend and colleague, Jerry Jacobs, has written a book about community delivery of psychological first aid in community settings. And so that's a really good book. But the one thing I do want to caution you about is that it's really important that even as trained clinicians, that we don't show up unannounced or unvetted to any kind of a disaster site, we end up being one of the problems then, because they have to manage an excess of people, and they do a clearance check on each and every person that comes into a new environment, because there's a recognition that those who have been adversely affected are very vulnerable in that moment, and they want to make sure that they're protected by not having any predatory people entering into the area. So you do want to become affiliated with a known organization like Medical Reserve Corps or like the American Red Cross, and go through their training. And then from there, you can take part in terms of supporting others who are trying to recover.
And Alma, I would just like to add to that very quickly. Early intervention post-trauma, the kinds of interventions that are looked at in the research are actually not widely available anywhere. They're typically not deployed, for example, in disaster mental health, but they're also not deployed really in any of the settings. So it's actually rather difficult to get hands-on experience with early intervention methods that are thought to be the best kind of tools. So I do agree with Lisa, get involved, volunteer with Red Cross or Medical Reserve Corps, and learn what they do. But then also seek out those more special opportunities where you could work with specific groups like rape survivors, sexual assault survivors, combat stress, different places where trauma survivors show up more acutely.
Okay. An anonymous person wants to know, are there currently any unique interventions for eco-anxiety, pre-traumatic stress disorder? If so, who provides these interventions?
Well, yikes. I don't think so. I have been thinking about this, and just sort of a good way to deal with eco-anxiety, right? And worrying about the future of the world and the death of all our beloved species and the coming Armageddon of international conflict and all that is to get involved in climate change activity. Mm-hmm. So one of the interesting issues about this is, if you think about disaster mental health, it actually doesn't speak to climate change. So most of the people deploying and learning disaster mental health interventions, they're not even going to refer to climate change. In the United States, of course, it's a political hot potato, so it's even difficult to raise the subject without encountering certain kinds of political forces. But I think that we need to add to the mental healthy things we do, right? Mental health things help you cope internally. They help you with your intrapsychic challenges. So we relax our bodies, we look at our self-talk, we solve problems differently, we reach out and give and get social support. Those things are great in keeping us calmer, but they don't tackle the problem, right? They do nothing to tackle climate change. So I think that one of the best mental health interventions for a person is to get involved in certain kinds of local or national activities to address the problem. So if you are concerned about species extinction, join an organization and get involved. Start supporting the development of a local green space. Green space is good for human emotions. People who spend more time in green space are calmer and more mentally healthy. Ditto with using public transportation or riding bikes to work. But getting involved so that you can feel that you are doing your part, whatever that is, whatever's possible within your span of time and energy to address the problem, because that's going to help you with your mental health problem. It can be supplemented by the mental healthy things we do on emotional self-management, but it also then begins to affect the world out there. So, it's kind of like problem solving. Problem solving is an intervention for depression. It doesn't solve it by helping you look at, being calmer inside yourself. It helps you because you're doing something to fix the situation. So I think that mental health needs to incorporate that. We need to encourage young people who are concerned about the future to get involved. That will empower them, make them feel more in charge, and will help them with eco-anxiety as well as doing something about the situation.
Okay. Ketrin Hodgson says, I believe in preventative approaches and am reminded of the neuroaffective relational model for work with complex trauma. Is there a prevalent model being utilized with this population, and how effective are they? By the way, we have about 4 minutes and maybe 1 or 2 more questions after this.
I'm going to defer to Joe on that one.
Well, I don't know what that model is. The question is there an evidence-based sort of prevention model?
Is there a prevalent model being utilized with this population, and how effective are they?
So the short answer to that is, one of the problems in the field of disaster mental health, in my opinion, is that there's not enough science. There's been a lot of studies of following disaster survivors over time and documenting the rates of problems. All that stuff's mapped out extremely well. But there's been very little research really on disaster mental health intervention, so much so that I don't think we have brought science to bear. And I think it's one of the weaknesses of our current disaster response system in the United States, the crisis counseling grants that go out and help us in big disasters, that they don't include systematic or strong evaluation components. So we know very little about whether they are being effective or not. So, but there are things. Let me tell you about something which I think is part of the future. It's a little bit like SPR, but there's the World Health Organization has an intervention called Problem Management Plus, and it's a brief 5-session, very simplified approach that teaches a little bit of solving problems, slow breathing, social support, and so on. That's being tried in Kenya and Pakistan and run by local residents under training and supervision. And in 2 randomized controlled trials has had a significant impact on post-traumatic stress disorder, anxiety and depression symptoms compared to enhanced services as usual. So that's the future. It can be done, but we need to learn about it, master it, and we as mental health professionals have to roll it out, train and support people around us in these tools.
Okay, Lourdes Robles wants to know, have you considered incorporating peer specialists in your program?
Yes. Peer specialists are really important. I think that, again, when oftentimes we get really short-staffed, we get under-resourced, we can get spread really quickly. I would say right now, back to Joe's point about not having adequate research to really show which responses and which treatments are most effective. Same thing with the peer response. When I look at what some of my colleagues in Canada are doing, there's a whole network about really exploiting peers to help extend their mental health service capacity. We haven't done that in the United States to the same degree. And I think that's a great opportunity. And I think that's something that really does deserve further exploration.
Okay, and Dr. Ruzek, could you repeat the URL about the coach?
About the skills for psychological recovery intervention?
I believe so.
That is at you can Google the National Center for PTSD, but it is at www.ptsd.va.gov.
Okay, we have about a minute. Any final thoughts from either of you? Joe, we'll start with you.
I just want to say, all of you who are mental health professionals, go out and get involved. Volunteer for disaster mental health, and also read the APA report on climate change and mental health, because you can play a big role in starting to link mental health into climate change. Get involved with local and regional climate change initiatives and go there and raise their awareness of mental health and help them think what to do to strengthen the mental health components. We've got to get more involved in the field than we have done. So I hope that all of you will see this as a personal opportunity as well as responsibility.
All right, Lisa.
And I would agree with that completely. I think it's important also, from my perspective, to partner with different community agencies that are not directly involved with the response. So for example, I'm working with churches in Oakland and San Francisco and helping their ministries develop programs that are robust, that they in turn can go out as trusted authorities already embedded in the community to reach out to people who may be realistically very wary of somebody from the outside coming in promising to do certain things. And so I think that doing more formal partnering with groups and back to the peer-to-peer approach, teaching them so that they can be, train the trainer, where they learn the skill set, they can continue to maintain it, and they can extend it further within their communities. That's just one example but there's lots of different organizations where a trauma-informed approach can be used, and that can be really a big game changer.
All right. Well, thank you so much. I want to thank all the attendees today. Dr. Joe Ruzek, Dr. Lisa Brown, thank you for your insight today. Very wonderful. And again, we're going to have a recording of today's webinar. It's going to be emailed to everyone within a few days. You can also find it and other webinars on PAU's YouTube channel. And if you have more questions, you can also email. Just go to externalaffairs@paloaltou.edu. But for now, we're going to wrap it up 2 o'clock on the dot. Thanks, everyone.
Bye, everybody.
Thank you.
Thank you.
Bye.